This was a 25-year-old male, a case of roadside accident. Bike slipped on the road and a patient had handlebar injury in the abdomen. Patient presented 7 days later with pain abdomen. His serum amylase was 280, was mildly range, upper limit is 70, and rest of the workup was normal. Dense fluid with echo seen in the pelvis, query pancreatic ascites, residual pancreas seen in the proximal head and uncinate process. This is the CT scan of the same patient in which there is a large collection in the pancreatic area. Whole of pancreas is replaced by this fluid collection and only viable pancreas in the head, which is highlighted by the black arrows, and portal vein can be seen. And this fluid collection was replacing most of the pancreas. Please share your management plan in the comment section. Welcome to our channel, viewers. The topic for today's video tutorial is changing paradigms in the management of major pancreatic injury. In this video tutorial, we have discussed in detail about the management of pancreatic injury as per the latest East 2016 guidelines. We have discussed step-by-step management for each grade of pancreatic injury and reviewed the latest literature. We have given two case scenarios also in this presentation and have tried to make a plan according to the present consensus. So stay tuned. So the anatomical area of the pancreas has been classically called as a tiger country because here there is a fight between two tigers, that one tiger is surgeon, another tiger is pancreas. And historically, it has been no go area, and surgeons were advised not to venture in this area. Otherwise, it will lead to a lot of morbidity, mortality, and bloodbath because it is a fight between two tigers. As I said, one is surgeon, another is pancreas. But the things have changed now, and we are frequently visiting this tiger country and coming safely, and patients are going home safely. This is the first case scenario. In that we have a 29-year-old male with a history of road traffic accident. Patient had pain right upper abdomen at presentation and an episode of vomiting. Except for the abdominal distension, there was no other physical finding. Initially, patient was managed at local hospital and was referred to us after 3 days after suspicion of pancreatic trauma based on ultrasound abdomen. On examination, patient was hemodynamically stable with no positive physical finding, and his laboratory parameters were normal except for low hemoglobin that was 9.4 milligram and raised serum amylase that was 7,301 international unit per ml. On CT abdomen, it showed complete transaction at the neck of pancreas with fluid between pancreas and splenic vein with grade 2 liver injury. So this is the CT scan of the same patient as we discussed, in which inside the circle as highlighted by the arrow, there is a complete transaction of the pancreas and it is reaching almost up to the splenic vein. And as I said, there was a fluid between pancreas and splenic vein. So there will be a grade 3 splenic injury as per the asked classification. Dear friends, please make your plan of management for this patient, and I'll discuss our management at the end of this video tutorial. And after reviewing the literature, I hope we will be more wiser and will be able to manage this patient more efficiently. So kindly make your plan right now, write it down, and let's see what is your plan and does it match with our plan or not. Coming to the pancreatic injury. So, brief introduction. It is a relatively uncommon organ to be injured in blunt trauma. The incidence is 5% in blunt trauma, around 6% for gunshot injury abdomen, and 2% for the stab injury. Penetrating trauma abdomen is the most common cause of pancreatic injury, which accounts for more than 70% cases of pancreatic injury. In India, approximately 1.18% of all trauma admission has associated pancreatic injury. Isolated pancreatic injuries very uncommon and rare. As I said, coexisting injuries are very common with pancreatic injury, and there are chances of 50% to 98% associated intra-abdominal injury if a patient has pancreatic injury. The associated pancreatic duct disruption in pancreatic injury patient has 15% incidence. The mortality of this trauma is very high, that is 36 to 60%, and mortality is 9% to 34%. The majority of deaths occur within the first 48 hours due to massive bleeding and its complication. The later cause of death is due to cysts, sepsis, and multi-organ failure, which accounts for the major deaths after 48 hours. So, how to diagnose a patient? First, will be clinical, and we should have strong suspicion if there is a history of blunt trauma or a heavy object falling on the abdomen, especially in the epigastric region, or there is a road traffic accident with handlebar injury or seatbelt injury. Another is biochemical, that will be discussed in detail, and radiological. Coming to the biochemical analysis, the cornerstone of diagnosis is amylase and lipase level. So serum amylase is elevated in 80% of patients with blunt pancreatic injury. An elevated amylase level mandates a direct evaluation to rule out pancreatic injury, and studies has shown that amylase level upon admission are not very sensitive. That we will see again in subsequent video. The diagnostic yield of amylase is time sensitive. The normal serum amylase is found in 35% of patients with complete main pancreatic duct transaction. A value obtained 3 to 6 hours after presentation has much higher accuracy in predicting the pancreatic trauma. So, serial or delayed measurement of amylase are more useful. So, this is a study published in Annual Surgery by Takishima et al. So, they have shown the relationship between the serum amylase level on admission and time elapsed from injury to admission. So, they have studied total 73 patients, and they noticed that the serum amylase level within 3 hours of the admission had a normal level in 35% patient in first 1 hour, 21% patient in 1 to 2 hours after injury, and 15.4% patient in 2 to 3 hour injury. If the amylase level was sent in 3 to 4 hours and 4 to 5 hours or more than 6 hours after injury, the number of patients with normal amylase level dropped to 0%. And this is a very significant study. And so, any patient in which we are suspecting clinically there is a possibility of pancreatic injury or the symptoms are not explained by other investigation method, we should send a serial amylase level, especially after 6 hours. And if they are rising, that are pointed towards the pancreatic injury. For radiological evaluation, ultrasound accident fast will be part of evaluation of any blunt trauma abdomen, but usually ultrasound is not sensitive enough to pick up the pancreatic injury, and the gold standard for diagnosing pancreatic injury is CCT pancreatic protocol. As the pancreas is a retroperitoneal organ, so the ultrasound has very low sensitivity for detecting the pancreatic injury. So CT is the initial study of choice. As I said, it is the gold standard for diagnosing the pancreatic injury. Earlier CT scan has overall sensitivity of 68%, and the reference for these data I have given in the video. False negative in less than 12 hours after trauma is chances are 20 to 40%. That we should remember that CT may not pick up the initial pancreatic injury finding in less than 12 hours, as there are little change in the density and minimal separation of the laceral pancreatic fragment. Multi-detector CT scan in portoluminous phase has higher accuracy for detecting the pancreatic injury. Approximately 5 to 10% of MPT injury are missed on CT scan. And if there is a clinical doubt and in the scenario of raised amylase level and normal CT scan, we should repeat the CT scan after 8 to 12 hours after the admission to detect any missed injury of the pancreas. In multi-center study, examining the use of CT scan by AST, that is American Association of Surgeons for Trauma, had given these signs as a hard sign for pancreatic injury. That is active bleeding from the pancreatic tissue. There is a pancreatic hematoma or laceration. There is a diffuse enlargement or edema of the pancreas or low pancreatic attenuation. And they said that laceration of more than 50% of gland thickness on CT scan should raise concern for pancreatic ductal injury. Okay. Okay. So this is the ASK classification of pancreatic injury, in which the pancreatic injury has been graded from grade 1 to 5. Grade 1 and 2 has two components, that is hematoma and laceration, and grade 3 onwards are laceration only. So grade 1, if hematoma is a minor contusion without duct injury or tissue loss, or laceration, this is a minor laceration without duct injury or tissue loss. Grade 2, hematoma involving more than one portion, we will see in the picture also, and laceration with disruption less than 50% of circumference. As I said, if the circumference involved is more than 50%, we should suspect the major the MPD injury. Grade 3, laceration, there is a distal transaction or pancreatic injury with duct injury. If duct is involved, it becomes grade 3 injury. And grade 4 is laceration, which is proximal to the spleen-preserving vein, or there is a major pancreatic injury proximal to the spleen-preserving vein. Grade 5 is again laceration, there is a massive disruption of the pancreatic head. Okay. So figure B, that is the grade 1 injury. There is a hematoma which is involving only one portion of the pancreas, that is the neck in this case, and or a laceration which is not involving any tissue loss, or there is no duct disruption. Grade 2 is when the hematoma is involving more than one portion, that is in this case is extending from the body to the head, and neck is also involved, or there is a laceration with tissue loss without duct injury. Grade 3 is when there is a distal transaction or there is a pancreatic injury which is involving the duct that leading to the leak of the pancreatic juices. Grade 4 will be laceration which is proximal to the spleen-preserving vein, or there is a major tissue loss proximal to spleen-preserving vein towards the duodenum. And grade 5 is major disruption of the pancreatic head. What is the role of MRI or MRCP in the management of pancreatic injury? So we have to understand the concept of dynamic secretin stimulated MRCP, in which we give secretin to enhance the secretion of pancreas, and I don't think it is available at much center, but theoretically we should be knowing about this modality of MRI or MRCP for diagnosing the pancreatic injury. So as we know that it is non-invasive, and if we add secretin stimulated MRCP, then it's a dynamic deformation for continuing leakage. It's more useful in chronic or delayed setting, difficult in acute setting due to its a time consumption. Only a few case series for its use for pancreatectomy, so no current valid recommendation can be made for this technology. So if we have label, we can use it, but there's no literature evidence that it should be done or should not be done. Intraparenchymal hematoma may cause duct compression, showing as a loss of duct on MRCP, that we have to keep in mind. If there is a intraparenchymal hematoma, then on MRCP that will show a discontinuation of the duct, and it will upgrade the injury grade to grade 3 or higher. And differentiating from true duct disruption may require ERCP. ERCP, as I said, it is the gold standard for diagnosing the major pancreatic injury and in defining the continuity of main pancreatic duct, especially in the doubtful cases, and precise localization of the site of ductal injury. During ERCP, it is also becomes therapeutic also, that we can place stents and useful adjunct to non-operative management, and it is a complement to surgical treatment of proximal pancreatic injuries. The risk is during ERCP there can be exacerbation of the pancreatitis and sepsis from overfilling of the disrupted duct. This is an ERCP image which is showing a leak or exacerbation of the contrast from main pancreatic duct, suggestive of grade 3 injury, and there is a major disruption of the pancreatic duct leading to a leakage of the pancreatic juices. There is a classification by Takeshima et al. Of pancreatic injury by ERCP, in which it is grade 1 to grade 3. Grade 1 is normal pancreatic duct on ERCP. Grade 2A is injury to the branches of main pancreatic duct on ERCP with contrast extravasation inside the parenchyma, and 2B is when there is a contrast extravasation into the retroperitoneal space. So grade 2 is for basically branches of the main pancreatic duct, not the main pancreatic duct. When main pancreatic duct is injured, then it becomes grade 3, and grade 3A will be injury to the main pancreatic duct on ERCP at the body or tail, or if it is proximal in the head, then it becomes grade 3B. Coming to the management of pancreatic injury, this is a landmark paper by Vanessa Fields et al. And it is a practice management guidelines from the Eastern Association for the Surgery of Trauma, that is EAST 2016 guidelines. So, in this review paper, that is systemic review level 3 evidence, they have reviewed all the published literature from 1965 to December 2014, and after studying all the articles, they have given these recommendations. The background of this paper is that traumatic injury to pancreas is rare, but is associated with significant morbidity and mortality, including fistula, sepsis, and death. There are currently no practice management guidelines, and these were the first practical guidelines for the management of pancreatic injury. The first question answered in these guidelines is that for a blunt trauma abdominal patient, if during a routine CT scan of the abdomen, grade 1 or grade 2 injury to the pancreas identified, so should we do operative intervention or non-operative management for this patient? The recommendation is for grade 1, grade 2 injury identified in preoperative CT scan, non-operative management should be done. Further study is required if there is any case regarding there is any doubt regarding the ductal integrity that may be ascertained by ERCP or MRCP. And if surgery is undertaken for this patient, then the pancreatic injury is to be managed by non-resectional management. That is, we will not do anything surgically to the pancreatic injury for grade 1 or grade 2 patient. The second question answered in this guideline, that East 2016, is if preoperatively we detect the injury, that is grade 3 or grade 4 pancreatic injury in CT scan, what should be the treatment? So, they have said that 87 patients were operatively managed and 16 patients were managed non-operatively in this review. One patient died in each group. 29% patient, that is 7 out of 24 of the operatively managed developed fistula, compared with 60%, that is 9 out of 15 of patients who did not undergo an operation. So the rate of development of post-operative pancreatic fistula was significantly more in non-operatively managed patient of pancreatic grade 3 and grade 4 injury. The largest series in this review article was by Vermos et al., in which 97 patients with blunt pancreatic and duodenal injuries were studied, and mostly patients had grade 1 or grade 2 injury who were initially managed non-operatively. Non-operative management failed in 10%, that is 6 pancreatic injury failed and 3 duodenal injury failed, and 1 with both. 4 patients with grade 3 growth injury to the pancreas duodenum had non-operative management attempted, 2 failed, so that the failure rate for grade 3, grade 4 injury was almost 50%, though the number was less, that was 4 patients only. And the failure rate for non-operative management for grade 1, grade 2 injury was 10%. And so the authors concluded that the high grade injury, the operative management is a preferred mode of treatment modality. Further, the complication after failure of the non-operative treatment was 30%, and mortality in non-operative group was higher. The next question, which is answered in these guidelines, is for a patient undergoing operation who are intraoperatively found to have grade 1 or grade 2 pancreatic injury, like a patient of blunt trauma abdomen is undergoing a surgery for another indication, and during exploration or while opening the lesser sac, surgeon noticed there is a grade 1 or grade 2 pancreatic injury. Grade 1 will be a hematoma or laceration without any ductal disruption. So, in this review article, over 299 patients were identified in 14 articles. 27 managed in the resection group, and 272 managed in the non-resection group. So majority of the patients were managed in the non-resection group. Non-resection means the injury was not touched upon or it was not treated and it was managed conservatively. The reported pancreas-related mortality in the resection group was 4%, that is 1 out of 25, versus 0.9% in non-resection group. So if grade 1, grade 2 patient were attempted surgery while undergoing surgery for other indication, the mortality was high and it was statistically significant. Fistula rate was 14.3% in section group and 10.6% in non-section group. Again, it was significant finding, and intra-abdominal assays were also higher in the section group. So, for the management of grade 1, grade 2 intraoperative finding, non-resectional management for operative management of grade 1 and 2 pancreatic injuries there. That is, if patient is undergoing surgery for for indication other than pancreatic injury, and intraop we have a grade 1, grade 2 injury, then it is a conservative management only and it is not to be dealt surgically. Thank you very much for watching, guys. I hope we were able to add some new insight to your knowledge, and we will be able to manage pancreatic injury patient better. Please don't forget to like this video and subscribe to channel and hit the bell icon. The channel subscription is free for lifetime and knowledge is invaluable. Thank you very much again. Happy learning.